Welcome to part 1 of respiratory failure. You can find this on pages 38 and 39 in your Nurse Workbook 2.0. And the purpose of this video is to provide you with more education beyond the Nurse Workbook, but give you real-world nursing education as well. And in this video, we're going to talk about ARDs, or acute respiratory distress syndrome. And ARDs can always lead into respiratory failure. Almost everything that we've talked about so far in this respiratory module can lead into ARDs and eventually into respiratory failure if we don't act fast enough or we give these patients the appropriate treatment. And this is also going to go more advanced into our hemodynamics. And so it's great that we've learned all of our ventilation terms previously and also a lot of our mechanical ventilation terms as well. So let's get started. So ARDS is acute respiratory distress syndrome. And ARDS is an inflammatory lung disease that is secondary to another problem, like our sepsis or trauma or shock, our pulmonary embolisms, or maybe a massive blood transfusion. And when we have ARDS present, we're normally going to see that respiratory distress. We might see a dry and frothy cough. And this could be from fluids leaking out of our capillaries and now into our patient's airway. We could also hear crackles and rhonchi present from a whole bunch of crud in our lungs. We might even hear diminished lung sounds, and this could also be from a whole bunch of stuff where our air exchange isn't going very well, so we're not hearing much movement. And we also can see bilateral infiltrates. And bilateral infiltrates can happen pretty much almost from the same reason as our dry, frothy cough, because our capillaries are leaking from this fluid buildup or this inflammation going on. And we can get this leaking in our interstitial space, which can give us those infiltrates. And we're gonna see worsening of our PaO2, or our partial pressure of arterial oxygen. And this is gonna be because of that gas exchange. We're not having good gas exchange or that diffusion going on. And so this is gonna affect our PaO2. And the biggest takeaway from these signs and symptoms is that it's gonna be really obvious if our patient is in acute respiratory distress. If they're not on a ventilator, you're gonna see it all over them. They're gonna have such a difficult time breathing and they're going to look very sick. And if they are already on a ventilator or maybe a different kind of oxygen form, we're gonna notice that that gas exchange and their oxygen levels and their vital signs are not where we want them. We will see this progression go down. But if they are on the ventilator, good news is there are things we can do to try to compensate for this acute respiratory distress. So let's understand how we diagnose ARDS. And this can be from a chest x-ray or arterial blood gas. And we can see if there's any acid-base imbalance going on. We also want to look for that PF ratio, and we're going to talk about that in our next video. We can also do a bronch sputum test, and although this doesn't necessarily tell us if they're in ARDS or not, this is going to give us the sputum to test what kind of infection possibly there is in there, so we're able to treat it appropriately. And we also want to rule out cardiogenic pulmonary edema, and this is a big one because ARDS is from an indirect lung injury. So this means something else is bringing on this acute respiratory distress syndrome. And so this is backing up fluid in the lungs, it's causing our capillaries to leak, and it's doing a whole inflammatory cascade of events. But in cardiogenic pulmonary edema, this can present the same way as ARDS, but this is from our cardiopulmonary vasculature. And this is because of our heart and that ventricular failure that we're having this cardiopulmonary edema. So if we don't diagnose this appropriately, we could do 2 different courses of treatments, and this could make whichever one it is worse if we're treating something different. So let's break down what ARDS is doing to our body and as it progresses. And we're going to start with this healthy alveoli. And this pink layer is the outer shell of our alveoli. But we want to slice this in half so we can look inside. And this yellow layer is going to represent our surfactant. And this is that substance secreted by our alveolar cells that reduces surface tension to prevent our alveoli from collapsing during exhalation. On top of the alveoli are blood vessels, and these are so tiny that blood is going to line up single file to flow through them, known as our capillaries. And this inside is going to be where diffusion or gas exchange occurs. And this blue layer represents oxygen coming in and out that we inhale and exhale. This is where that diffusion is going to take place, or that gas exchange that we keep talking about so much. So our red blood cells are dropping off our CO2 and they're picking up their oxygen. And our ARDs is going to follow a cascade of insult to our alveoli. So here's going to be the start of injury to our alveoli. First, we're going to see this release of cytokines and leukocytes, and we see this in that yellow and green right here. These cytokines and leukocytes are our body's protection mechanism, and we're trying to fight infection. We're also maybe trying to fight any foreign invaders at all. So they have this great intention to try to help our body out. The problem here is, even though the intentions are good, this is spiraling out of control. They're sending way too much of an inflammatory response, and so this is actually doing more damage. So this is going to cause a bunch of inflammation, and our histamines are going to release. These histamines also have good intentions, but they actually create more inflammation and fluid leakage inside our alveoli because of this extreme response. So we're going to see an increase in the permeability of the capillaries. And our fluid is leaking into the interstitial space between our alveoli and this blood vessel, which leads us into this alveoli collapse. And this is going to mean that fibrosis from the inflammation is going to cause stiff lungs, more fluid buildup, and it leads to pulmonary edema and into our respiratory failure. So if we look right here, we see everything, our cytokines, our leukocytes, these histamines, but now our alveoli is even collapsing. And there's going to be a lot more fluid in between the spaces of our alveoli and these blood vessels. And as you can imagine, this is going to significantly impair our gas exchange. We're also going to see this decrease in our vascular flow as well. And all of this is going to lead to our respiratory failure. And our respiratory failure is a condition that impairs the lungs from oxygenating blood and expelling carbon dioxide. And this happens when the body can no longer compensate. So on our blood gas, the biggest indication of this is going to be that our PaO2 is less than 55, or our PaO2 is going to be greater than 50. And this makes sense, right? Because we're not absorbing a lot of oxygen, and we're definitely retaining that carbon dioxide as well. And this concludes our respiratory failure part 1 lesson. I will see you in the next one.